Welcome, everyone. Welcome to our July 2024 session on global perspectives on medicine, rehabilitation, and robotics. Today, we have a wonderful presentation on automated assessments of infants at risk for physical disability. And we have three presenters who will present on this topic to us today. Our first presenter is Laura Prosser, who is an associate professor of pediatrics in the Division of Rehabilitation Medicine at the University of Pennsylvania and the Children's Hospital of Philadelphia. Dr. Prosser's work focuses on the development and rehabilitation of impaired movement in children with cerebral palsy and infants at risk for cerebral palsy. Our second presenter is Julie Skorup, who is a physical therapist at the Children's Hospital of Pennsylvania. Julie focuses on working with children with neuromotor disabilities such as cerebral palsy in multidisciplinary clinic settings and participates in research for infants and toddlers at risk for neurodevelopmental impairment. And our last but not least presenter is Melanie Sigado, who is a postdoctoral research fellow in the School of Engineering and Science at the University of Pennsylvania. Dr. Sigado's research focuses on leveraging cutting-edge AI technologies to advance the study of movement and develop innovative clinical tools. So I'm going to turn it over to our presenters. Just as an FYI for all our attendees, you can post questions at any point of the presentation in the Q&A box, and we'll field them at the end of the presentation. And if you can just leave yourself on mute so we don't interrupt the presenters during their presentation. All right, so I'm going to turn it over to our presenters.
Thank you, Dr. Mendonça.
Welcome.
All right, so the group of us here, Julie, Melanie, and I have been collaborating for the last several years on this work, and we're really excited to share with you our efforts in moving toward automated assessment of infants at risk for physical disability. Next slide. So we have three sort of main objectives for the talk that will frame how we present this information. So the first is we'll describe the importance of early detection for motor impairment in infants and why this really is a critical time. Infancy is really a critical time for this work. Next, we'll review current international consensus guidelines for the early diagnosis of cerebral palsy. And then finally, introduce our efforts to automate the early detection of motor impairment that leads to physical disability. Next slide. So cerebral palsy is the most common cause of physical disability in children, and it results in a permanent disorder of the development of movement and posture. And the development here is really the important part. As a field in cerebral palsy rehabilitation, we have done much. We've been stronger at understanding the impairments and the functional limitations in school-age children with cerebral palsy. And we really, not until the last 10 and 20 years, have understood much better or made efforts to understand what is really happening in the early months and years of life when the ability to learn to move is failed or impaired. And so that's sort of our focus of what will be, of what much of our work is and what we'll be sharing today is what might be happening and how can we be detecting very early before the traditional signs like missing motor milestones, like not able to walk and missing the ability to sit independently, for example. Before those fail, can we be detecting the likelihood of impairments in the development of motor control early in life? Next slide. So the first 2 years of life are a critical period for the development of motor control. There's a lot of evidence from basic neuroscience that supports this, both in animal work and now in human infant work. So this could be the topic of a entirely different seminar. But the field really rapidly is moving toward this notion that our efforts really need to be fairly intensive and fairly targeted to these first 2 years of life, because this is the time when in typical development, infants' brains are learning how to move their body. Next slide. And we see this evidence in children with cerebral palsy also. So here we're showing gross motor trajectories for children at the 5 different severity levels. This is a GMFCS, is the gross motor function classification system. It's a 1 to 5 severity classification, with children who function at level 1 having impairments in what we would think of as higher level motor skills like walking, running, and jumping. Children at levels 2 and 3 walk, but with noticeable impairments or need for assistive device. And children who function at levels 4 and 5 have more significant functional mobility limitations, requiring assistance from others for mobility and for self-care. And so we see these trajectories. Now, this classification is remarkably stable after the age of 2. And Melanie, if you can just animate that, the next 2, yep, but under the age of 2. So next animation is shown in yellow there. So these classifications, unlike after the age of 2, when these are remarkably stable, regardless of therapeutic, rehabilitation, surgical, or pharmaceutical intervention, there is not much change in these severity levels once motor control is broadly established. But before age 2 is really an exception. And you can see how close the trajectories are to each other before the age of 2. So it's quite hard to distinguish at a young age what the functional prognosis for a particular child is. And how close these curves are to each other before the age of 2 also suggests that early experience may matter. And if we can make small changes in the first 2 years of life, we may have big impacts on the trajectory of gross motor function throughout the lifespan. Next animation. So one more note on this graph is these vertical dashed lines that the authors term the age 90. This is the age when 90% of gross motor function is reached. And the take-home message here is this is really, really young. And it is younger with increasing levels of severity. So even children who function at level 1, the least impaired category, they are reaching 90% of their gross motor function on average by the age of 5. And children who function at level 5 are reaching 90% of their gross motor function before the age of 3. And so we have this short window of time when we might have the best chance of influencing the trajectory of gross motor development. Next slide. So we also know from clinical trials that early motor experiences can improve outcomes. And there's now, from just a couple of years ago, clinical practice guidelines for what early intervention should look like. But motor training and motor practice is the most effective intervention to improve long-term gross motor abilities in these infants who are at risk or are diagnosed with cerebral palsy. And we now have these clinical practice guidelines. These are quite broad. And I'll refer you to the paper. This is by Kathy Morgan from Australia, who led an international consensus team for these guidelines. These include things like family support for practice and problem solving from the child. So really, it is not specific protocols, and it doesn't match specific interventions yet to particular infants' characteristics, like based on the distribution or the severity level of cerebral palsy. So this work is a great first start. It's new in the field, but we need to get beyond this work to more of a precision rehab approach where we can really tailor the right kind of interventions to the children who will benefit the most in the early months and years of life. And sensor instrumentation, and rehabilitation robotics, I think, give us an opportunity to move in that direction. Next slide. All right, you can just animate this whole slide, Melanie. So I think of this sort of cartoon here as what we need tools to do in terms of distinguishing infants in the early months of life. And so we could have 3 infants who have the same medical history and the same current medical status. For example, they might have been born preterm, they might have a mild brain injury. And it is really uncertain how each of these children will progress in terms of the development of their motor control. And so one of these children in the yellow boxes may have normal motor control and typical motor milestones. So they might lift their head, sit, crawl, and walk, all according to, within the published norms for these milestones. And for this child, we would need to give this child no intervention. They don't need to be referred to, in the United States, what we would call early intervention services, birth to 3. They could proceed with their family and not have any monitoring beyond the usual well baby or general pediatrician monitoring. The second baby might have normal motor control, but delayed milestones because of their medical history. They might be slow to achieve the milestones, but their brain is learning how to move quite typically. And so for this patient, the intervention is short-term rehabilitation services. Here in the US, that would be birth to 3, which often comes to the home, and parent education to support developmental goals, like developmentally supported care and environment. The third child might have impaired motor control and delayed milestones. Our current tests will pick up the delayed milestones, but are not so good at picking up impaired motor control. And this is the child that will have lifelong physical disability and lifelong rehabilitation needs. And this is the child where rehabilitation has the best chance in the first couple months and first 2 years of life to change the trajectory of this child's gross motor development. And so we need tools that can really help us distinguish between each of these 3 categories of infants so that we can tailor the provision of healthcare services to what they need most and give deliver the services to the children who need it the most. Next slide, which I think is Julie. Yeah.
Okay, thank you, Laura. So I am going to talk about the current tools that we have for early identification of CP. Next slide. So this is a decision tree that was published by a group out of Australia in 2017, and this really is the guideline that we use now to help identify CP earlier in infants even younger than 5 months of age. And so we can look at this tree in 3 sections. So that top section in the first bracket is the history section, that middle section, and that green in the second bracket, that's the green, blue, and beige. Those are the recommended examination tools. And then the bottom is what we do with that information to help determine if there is a diagnosis of CP and then the action to take from there. Next slide, please. So I broke this table up into 2 different sections just so we can look at it a little closer. So this top part is looking at the history. So is there a detectable risk that warrants concern for cerebral palsy? And so there could be a newborn detectable risk, such as the baby was born prematurely or encephalopathy at birth, or an infant detectable risk, such as the parent is just identifying concern for the way the baby is moving. Maybe the baby is not hitting their milestones, or even at 9 months of age, the child is not sitting yet. And so if the child does have a risk that warrants further investigation, the recommendation is to take a thorough medical history, do a clinical exam, and then do a battery of neurological, neuroimaging, and motor tools to help determine if we think this child does or does not have CP. So you can see in the next part that this is separate. The left side of the table is for infants that are under 5 months of age, corrective for prematurity, or over 5 months of age. So there's 2 different pathways that we can take based on the infant's age. The first green box there where the arrow is pointing, these are the clinical neurological exams. And so regardless of patient age, the recommended exam here is the HINE. So that stands for the Hammersmith Infant Neurological Exam. The next strip in the blue where the second arrow is pointing is neurological imaging. So if this is available, the gold standard of imaging is really to get an MRI. If MRI is not available, the second recommendation is to do serial head ultrasounds. But you can also see that neuroimaging is not always going to be an option for all of the babies, and it is okay because it is useful to have. It can provide information, but you don't have to have it to get a diagnosis of CP. And so regardless of if imaging is possible or not, we move down to the next strip, which is the motor test. So that's highlighted in beige there. So these are the tests that are really looking at infant movement and motor performance, developmental skills to determine if there is a motor delay. I highlighted 3 that are circled here in purple, the general movements, the TIMP, and the AIMS. And those are the ones that I'm just going to spend a little bit more time talking about today. Next slide. So you take all that information and then we move down to the bottom part of this clinical decision tree to use the neurological exam, the imaging, the clinical history, the motor assessments to determine, yes, this child definitely has cerebral palsy. No, they definitely do not. Maybe it's unclear, but likely not CP. And then there's also this other category, which is high risk of CP. So no, we cannot make a definite diagnosis today, but we think that this child is still at very high risk of having a CP diagnosis in the future. Next slide. So looking at CP diagnosis from that same paper where the decision tree was published, the recommendations for tools that really, if you only had to pick 3 that give the most information that have the highest sensitivity for diagnosing CP. For infants under the age of 5 months, having an MRI, doing the general movement assessment and a HINE assessment. And then over the age of 5 months, it would be having an MRI and the HINE neurological assessment, and then another developmental assessment that's called the DAISY. And these really give the best predictive information, especially when used in combination. And for both age groups, again, we just want to have a clinical assessment that shows that there is a motor delay because that really is key. It's not only just having the brain injury, but also having a neurological impairment with a motor delay to distinguish these kids as having risk of CP or CP compared to babies who have brain injuries but don't have these impairments. Next slide. And then to determine the at-risk for CP diagnosis, these are the babies that have motor dysfunction. So we're seeing abnormal movements, they have a significant motor delay, and they also have that risk factor of a brain injury. So neuroimaging or medical history where they have HIE at birth or a stroke at birth, seizures, accidental or non-accidental brain injuries, among other risk factors. Next. And you can see that going back to our decision tree, regardless of if the child has a definitely CP diagnosis or a high risk of CP diagnosis, we take the same path from there. And so the next step is that we have some tools to help preliminarily young determine what we think the severity of CP will be, and also possibly what the topography, so what areas of the body might be affected. And so the biggest tool that we use for this severity is the HINE, and then also where the MRI, if there is an MRI, where the brain injury is in the brain. And so there are cutoff scores on the HINE where infants that are scoring even as young as 3, 4, 5, 6 months. If they're scoring below that score of 40, you see there, these infants are likely to be non-ambulatory. So that if you recall from the GMFCS slide, so levels, GMFCS levels 3, 4, and 5, with more impairments in their motor skills versus if they have a Heinz score above that cutoff, which is again 40, these children may be a little bit more mild and they will likely achieve ambulation. So those are GMFCS levels 1s and 2s. And so the really important reason for doing all of this is to be able to give the families more information. We want to communicate what we found to the parents, really give them the support that they need, start them in the education process, start them in really the acceptance process, and then arrange for early intervention services. So getting physical therapy, occupational therapy, speech in early and in and doing CP specific intervention. Next. So while CP diagnosis has really truly come a long way, including, historically and even just 5 to 10 years ago, the average age of diagnosis of cerebral palsy was 18 to 24 months, and we are really trying to push that younger. And as you see from our decision tree, even as young as 3 and 4 months making the diagnosis, there are still limitations in our current tools. First, we really need more precise quantification, not just ordinal or description of motor impairments and movement. And so an example would be, we want to know what an exact measurement is. We just don't want to know, is it short or is it long? Or we would like to know exactly how an infant's postural control is impaired or the movement is impaired versus can the child sit, yes or no? Also, we want to be able to make distinction between the types of motor control impairments and to assess quality of movement, not just movement. We want things like not just does the child reach, but is the child able to reach smoothly, coordinated? Do they hit their target on the first try? What is the speed of the movement? Is the left side moving the same as the right side? So we really want to be able to not just look at quantity, but we want to look at quality also. Next, we also don't have automated tools that we can use to assess spontaneous infant movement. And while again, these tools are really giving us a lot of great information, families really do need to have access to a local hospital or an outpatient clinic setting or a provider who is experienced with them, trained in them, and is able to administer them and then also interpret them. And finally, we not only need more precise tools to identify more precise motor impairment, but also we would like to be able to use these tools to identify endpoints in clinical trials. Next slide. So that brings us to the clinical trial that Dr. Prosser, Melanie, and I are all working on together, and that is called the PANDA trial. So this stands for Play and Neurodevelopmental Assessment. And so the purpose of this trial is to help detect neurological and motor delays earlier. And we know that early detection is key for better motor development. And the goal is to combine easy to collect, non-invasive sensor data with AI technology to advance early detection. Next. So I'm just going to give you a brief overview of the PANDA study, just to give you a little bit of background context. So the inclusion criteria for this study is infants ages 1 to 6 months of age. We have 2 different groups. So one is infants who have brain injuries at birth, and the other group is our healthy, typically developing controls. For the typically developing control group, the babies must be born at 37 weeks or later gestational age, so they cannot be premature. In the infant with brain injury group, they are often and can be premature. And they must, for the typically developing group, they must not have an other diagnosis that might put them at risk for a motor delay or neurological impairment. So we have 2 different cohorts of this study. So one cohort is the cross-sectional group. So these babies are enrolled and they do 1 research visit between 1 and 6 months of age. And then we also have the longitudinal group. So this group of babies are seen once a month from 1 to 6 months of age. So we are looking at them over time and tracking their development and changes. And then we see them one last time at 12 months of age, just for a cognitive and motor assessment. The study visit consists of a neurological and motor assessments, and these are completed by a physical therapist, and then also PandaMat data collection. So you can see there on the picture on the right, this is a baby who is doing the PandaMat data collection. So the baby is laying on a mat that is on sensors that's giving us center of pressure data. There are cameras that are giving us data on the infant movement. And then also not seen, there is a toy that looks like a panda that the baby can interact with at their hands or their feet. And that toy is collecting data on how the baby is interacting with it. And these study visits, as you can see in the picture, can be done really anywhere that the mat can fit. And so this specific one was done in the family's home. So it's able to be accessible in many different environments. Next. So the study assessment. So at each visit, I said there's a battery of neurological and motor assessments that's completed by a physical therapist. And so at every assessment time point, different assessments are completed basically based on the age that it's appropriate to complete it for that specific tool. And so we do a neurological assessment. So that would be the HNME or the Hein, and then we do motor and movement assessments. Next. And sorry, so that previous slide was the cross-sectional cohort. So those are the assessments that are completed each month for the baby, and those babies are just doing one of those month assessments based on how old they are when they are completed. This is the longitudinal assessment, and so again, all of these are the same as the cross-sectional batteries, but the difference is that all of the babies are completing each month visit, so they're having all of these done. And then at the 12-month time point, we have they do a Bayley for just cognitive and motor subsections. And the point of that assessment is for the typically developing group, we want to make sure that the babies do not have any cognitive or motor delays. And then for the babies in the brain inner group, we want to see how many of the babies do have impairments at 1 year of age and which ones do not. Next. So I am just going to spend a little bit of time talking about the different examination tools. So this first one is the Hammersmith Neonatal Neurological Examination. And so this was developed by Dubowitz back in 1981. So it has been around for some time. And this one can be used in infants that are young. So 32 weeks postmenstrual age. So in the premature infants, we can even use it before they reach their term age, and up to 6 weeks corrected age. This tool consists of items that assess tone, motor patterns, movements, infant reflexes, visual and auditory attention, and behavior. And this exam is scored based on gestational age of the baby at birth. So there are 90th percentiles, and these change based on how old the child was when they were born. And they have percentiles for infants from 25 weeks up to full term. And so if the baby scores on a specific item within the 90th percentile, they get a score of 1. And if they score outside of it, they get a score of 0. And so a study by Ricci showed that so they looked at infants at term age. So they were tested when they were term age, and then they did a motor developmental follow-up at 2 years of age. And so at term age, the infants who scored more than 7 items outside of the 90th percentile were at higher risk of having motor impairments at 2 years of life. And the babies that scored more than 12 items outside of the 90th percentile were at higher risk of having very severe motor impairments at 2 years. Next. So then the Hammersmith Infant Neurological Exam is similar to the HNME, but now this is used for infants that are starting at 2 months of age and then up to 24 months. And so this exam is a combination of neurological items, developmental milestones, and different infant behavior. And the Hein has a high predictive value for risk of CP in young infants. And so there are cutoff values for infants at 3 months and at 12 months. And if the baby score below these cutoff values, it is 90% predictive of having a CP diagnosis. And the group from Australia who created the decision tree, they found that at 5 months, the combination of having a low Heinz score below the cutoff with a positive MRI finding, so as in having a brain injury, is 90% accurate of having a CP diagnosis. And not only is this tool really important in diagnosing of CP and predicting it in the future, it also can help us provide information about the severity and distribution, which I touched on before. The next assessment is the general movements assessment. So the general movements is an assessment that looks at spontaneous infant movement at 2 different time points. So it's at term age, which is the writhing time point, and then at 3 to 4 months age, which we call the fidgety time point. General movements are defined as typical and distinct spontaneous movements that we see in infants. Really, they come before birth, and then we see them up to about 20 months post-term. We really see them until babies start doing more intentional and anti-gravity movements like reaching and rolling. Infants who do not have general movement, so they're impaired or they're absent, they are at higher risk of having neurological conditions such as having a CP diagnosis. So we look at the general movements during the fidgety time point. So this is the 3 to 4 month time point. It is a video assessment and it's completed when the baby is awake and calm, not interacting with anybody else or not interacting with toys. And so the baby is either scored as yes fidgety or no absent fidgety. And there is a very strong relationship between having a score of absent fidgety movements at the 3 to 4 month point and having a diagnosis of CP. And the group from Australia, again, back to our decision tree, they found that in babies who are under 5 months of age, so at the 3 and 4 month age point, if they have absent fidgety movements on the GMA and also a positive MRI finding, it's 95% accurate in diagnosing CP. Next. So the Alberta Infant Motor Scale is an observational assessment, and this is really a motor screening tool, and it can be used in babies right from birth up into about 18 months of age, but it really maxes out when the babies are walking independently. If babies start to walk independently, then we stop using it and move on to a developmental tool that more addresses upright skills. This assessment looks at infants that are in 4 different positions. So on their bellies, on their backs, in sitting, and in standing. And so the items we just look at the items and we just grade them as either they're observed, they did them, or they're not observed, they don't do them. And for clinical practice, you can take parent report for the items, which we always take a little bit with a grain of salt, but even better for clinical practice, you can also take parent video. And if you see the child doing this skill there, we can grade it as observed. And so there are some cutoffs for this assessment also. So infants that are scoring under the 10th percentile at 4 months of age are considered to have a motor delay. And then as the babies get a little bit older, so around 8 months of age, under the 5th percentile would be the cutoff for a motor delay. And then a paper by Colobi and colleagues looked at using the AIMS to help identify infants who are at risk for CP. So not a tool for diagnosing, but helping to identify kind of like where the babies were scoring who do end up having a diagnosis of CP later. And they found that using the 5th percentile cutoff is better for infants at 6 and 9 and 12 months, kind of indicating that the babies who do end up with the diagnosis of CP have a more significant motor delay, so using a more strict cutoff. Next. So the test of infant motor performance is an assessment that is used in infants ages 34 weeks post-menstrual age. So again, in premature babies, we can use it before they reach term age and then up to 4 months corrected age. And this assessment has observation of spontaneous infant movements and then assessment of the baby in different postures and the baby's movements. And it is used to identify motor delay or atypical motor performance. And also it's great because it can be used to measure motor change. It's not a tool that is predictive of cerebral palsy again, but it is used to identify that motor delay because, again, children who have a diagnosis, they have to have an accompanying motor delay to get a diagnosis of CP. Next. So the take-home message to all of this is that early diagnosis of CP, it is feasible. We are doing it, and it is really important because, again, we just want to make sure that these families are getting supported and that the kids are getting intervention while they're young, when it's most meaningful, and when we can make really the most change for them. And we do have tools that help provide a good picture of neurological function and motor assessment. But there are limitations in those current tools, such as they're not precise and they're not specific. And even, the TIMP, while it can be used to look at motor change over time, the babies may have to have a bigger change for it to really gather that, to really capture that change versus maybe a smaller change that could be captured by something more automated. And so we really do need automated tools that can look at infant spontaneous movement and make precise identification of motor delays early. And so that is what I'm going to pass off to Melanie to talk about.
Great. All right, yeah, so as was mentioned previously, I'm a postdoctoral research fellow in UPenn Bioengineering, working with Dr. Johnson, who is here, as well as Dr. Conrad Cording. And my main focus has really been on leveraging advances in artificial intelligence to help push this idea of early prediction of movement disorders using automated tools. So from what's been discussed so far, I think it should be relatively clear that the ideal process for early identification needs to be something that is low cost, accessible, and robust. Especially with a focus on global health, we really want to make sure that the entry point to early diagnosis is not something that requires specialized clinician hours necessarily, not something that requires logistically complex visits to hospital settings. And when looking at an at-home care setting, parents may not necessarily know what to look for early in life. Pediatrician visits are really short, so the spontaneous movements or deviations in spontaneous movements may not occur during the time point that this infant is being observed. So really, there is a need for some type of early at-home screening tool that can be used to flag whether an infant is at a higher risk of developing a movement disorder, as well as something that can collect easy quantifiable metrics that clinicians can look at to make optimal use of their time once they have the opportunity to see an infant. So from that vantage point, computer vision-driven approaches are extremely promising. Cameras are very prevalent. They're increasingly inexpensive for monitoring purposes. And there's plenty of evidence showing that movement features can be readily computed from 2D pose estimates that are derived from these top-down videos. Once those 2D pose estimates have been computed, machine learning tools can then be used to detect specific patterns of movement in order to arrive at some of these early predictions or give some of the metrics that clinicians would need in order to make their judgments. Previous work from this group being the Rehabilitation Robotics Group, as well as the Cording Lab, has shown that this is actually the case. So if you take movement features computed from these top-down 2D pose estimates, and you look at clinician scoring of infant neuromotor risk, you can see here that the computed movement features differ between a reference population of infants that are at low risk of developing movement disorders and a high-risk group that have been scored as being at a higher risk of developing movement disorders. However, this was in a relatively small cohort, and so our goal was really to take this and look if in a much bigger group we can find similar results. So I do want to address the question of why such a tool does not already exist. The videos that you've been seeing, or the images that you've been seeing of these points all over the infants, are not necessarily new in and of themselves. They've been around for close to a decade at this point. However, there have been recent improvements in available algorithms that have really changed the game in terms of the robustness of this approach and its ability to generalize to a larger population. Similarly, the widespread availability of cameras and computational resources has grown exponentially over the past decade and has really reached a point where developing such an automated assessment tool is increasingly feasible. Part of the reason for this is a push towards the availability of large open data sets for training. Any of these AI approaches require not just a few hundred videos, as is typically collected in even a large clinical study, or a few thousand videos, but really on the order of hundreds of thousands of videos, which is only available if algorithms can be trained on data that goes well beyond the scope of any one individual study. Similarly, because of the proliferation of large open data sets and the availability of tools, there's also been an improvement in the understanding of robust machine learning methods, especially with regards to what makes approaches generalizable beyond the original data set on which they were trained. So for anyone who might not be familiar, I'm just going to give a very quick primer on what pose estimation actually is and a little bit about how it works so you can understand why recent advances have made the development of automated tools significantly more likely. So step one in any of these approaches is detecting which part of a video is actually an infant. If we're looking towards the vision of creating a tool that can work on handheld videos in an at-home care setting, there are a lot of things inside of that video that may have faces, like teddy bears or other people. So the first step is really to make sure that we have a robust pipeline for detecting where an infant is in the video and what position they're in. The second one is detecting these key points. And by key points here, I mean skeletal key points. So if I have a pointer visible, you can see that here it is labeling, say, the elbows, the wrists, the shoulders, both of the eyes, the hips, the knees, the ankles, all of the skeletal points that would be needed in order to compute some of these features, like the angle of the legs or the movements of the wrist, that clinicians are using when they do visual observation. From that, you can derive 2D pose estimates to not just get the individual metrics for each of these different points, but also higher level derived metrics like whether an infant is rolling, whether an infant is making a specific reaching movement. You can start doing action labeling in order to get a better picture of what the infant is doing in that video without the need for a clinician to necessarily sit and go through the whole video. They would be able to get a summarized metric of what is happening. And the fourth step here is really about 3D pose. It's about tools that are going to move beyond just the skeletal key point annotations and really provide a 3D reconstruction of what that specific infant looks like and what its pose looks like in 3 dimensions, moving us increasingly close to capturing all of the information that would be obtained through visual observation. Here on the left, I just want to draw attention to the suite of tools that I am currently using to do these analyses, because they are very well implemented to be accessible for people that have a limited background in computer science. It's the OpenMMLab suite of tools. I highly recommend anyone that is interested in doing pose estimation to check that out. All right, so in terms of infant detection, previous approaches up until a couple of years ago really required students to do a lot of manual annotation on videos in order for the pipelines to even work. Images or videos had to be a specific set of dimensions. They had to be a specific frame rate, a specific resolution. They had to be in a specific orientation. Because new algorithms can be pre-trained on all of the available videos on the internet, much of the pre-processing requirement has been abstracted away. So new algorithms are much better at doing multi-person estimation, detecting when there are multiple people in the frame. They're much better at handling low light conditions and complex poses. They just do a better job of providing robust estimates out of the box. So here is one specific example of what that looks like in practice. On the left is the pose estimate derived from a previous algorithm from about 2017, where you can see that any of the pixels that are, or any of the locations that are occluded by the infant's foot or by the infant's hand were not included in the skeletal pose, whereas with modern algorithms, it captures all of the points very effectively. And the reason for this is that previous algorithms really required the specific pixel content to be consistent in order to be able to capture the key point which they're trying to model. So if the knee was hidden by a teddy bear, the previous algorithm was going to have no way of knowing that there was a knee there because that section of the video would look like a teddy bear. Whereas newer algorithms learn both the information in the pixels of a specific video, as well as their relationship to the other content around it. So as long as, say, the hip and the foot are visible, the algorithm will have learned that a knee has to be modeled at the specific angle and correctly place the knee key point. So the result of this is much better handling of, say, occlusion and low lighting. I'm just going to play a quick animation for you. This is from one of the brain injury infants. And you can see here that even though the ankle is completely occluded by a medical brace, the algorithm is still able to correctly track the position of the ankle almost throughout the entire video. So even as the infant rolls into increasingly complex positions, the algorithm can maintain tracking and continue giving a pose estimate despite these issues that would have previously prevented any type of significant pose estimation from occurring. So similarly here, we can see that as the infant kind of bunches itself up into positions that would typically occlude the areas of the video that would be needed to arrive at a pose estimate. Modern algorithms can handle this complex situation quite well, correctly inferring that this hand does not belong to the infant and giving you a nice reconstruction of what this infant roll actually looks like. And one of the nice things about having robust tools for doing pose estimation is that it is not the case that videos need to be sent directly to clinicians. Anonymized pose estimates can actually be sent to clinicians or can be used for analysis, facilitating the sharing of data between institutions and also facilitating the development of tools down the line where these pose estimates can be transmitted securely from a home or hospital setting to a specialized clinician that can perform an evaluation. So for instance, here, these are videos that were captured by a handheld iPad in the NICU as part of a collaboration at the Children's Hospital. Here are some of the movements captured for a 36 to 42-week-old infant. And then here are the movements of that same infant at the 3 to 4 month old time point. So they're obviously a little bit funny to look at with the head shape being completely obscured by the key points. However, you can see that many of the important parts of the movement, like the flexion of the knees or the flexion of the elbows or the general movements of the head are preserved in these skeletal representations, even at 2 dimensions. Okay. So we can get good pose data from videos, which is fantastic because videos are cheap, easy, and straightforward to obtain across a variety of care settings. So what happens next? So many approaches have tried to use pose estimates in order to arrive at predictions of either GMA score or early predictors of CP. However, we found that approaches so far have been quite limited in terms of the methods that they use that would prevent them from generalizing to a broader population. So for instance, they either rely on manual labeling of fidgety movements prior to training an algorithm, which will result in the algorithm being overly sensitive to that specific data set. So in order to address that, we wanted to ask the question of whether we can use machine learning to predict GMA score at the 3 to 4 month time point in a very large data set using simple, explainable, pre-registered features, meaning that clinicians decided on the features before ever looking at the specific data set, to see if we can get a robust machine learning prediction that we hope will really generalize outside of the data set on which it was trained. So the process for this was to collect a large sample of top-down 2D videos, to carry out the infant detection and 2D key point estimation, to compute a set of movement features, to train a machine learning algorithm to predict the GMA score, and then to test it on a held out set of 187 infants that were not viewed during any point of this pipeline previously. The features describe the posture, velocity, acceleration, left-right symmetry, and complexity of the infant movement, which was just described in many of these infant scales, not just the GMA. Specifically looking at a set of features across the ankles, the elbows, the general speed, velocity, and entropy of the effectors. All right. And to summarize what we found using this approach, what you're looking at here is the true positive detection of infants that were scored as having absent fidgety movements in the held out test set versus the number of infants that were incorrectly scored as having absent fidgety movements. And what we get is actually quite an interesting result. So we can get about 80% correct classification of absent fidgety movement infants while maintaining a reasonably low percentage of infants that were incorrectly scored as having absent fidgety movement types. In other words, we can correctly pre-screen infants for having absent fidgety movements without having to include any specific information about their movement type. It's just based on this general description of the movement features throughout the video. So this information could be extremely useful in order to determine which infants are at the highest risk of developing delayed motor development, or CP, which can then be sent to clinicians for further evaluation. All right, so we've shown that good pose data can be used to predict GMA score. What's next? We've also been able to show that these movement features can provide a robust prediction of infant age. So here we have that same cohort of infants, and instead of trying to predict GMA score, we were looking to see if we could predict the corrected age of the infant in weeks based on the movement features, which raises the possibility that even in the earlier cohort, we would correctly be able to predict some of these clinical scores, and we are currently working towards obtaining that information as well. We're also aiming to do integration of facial expressions. As Julie mentioned previously, these videos really rely on the infant being in the correct state. They have to be awake, they have to be not distracted, they have to be not interacting with anything at the time that the evaluations are performed. By moving towards a more integrative analysis type that considers both the context of the infant and their emotional state, we're hoping to improve the automated classifications and increase the extent to which they can be used outside of a clinical care setting. Similarly, clinicians, when they perform evaluations, have access to not just the 2D skeletal key points, but also to the 3D volumetric information about the infant's current health state, about their weight, about how they look more generally. And so we are also working towards integrating 3D volumetric mesh fitting so that any information that is obtained from these videos can also include information about the overall look and weight of the infant as well. So to summarize, modern pose estimation from cameras is sufficiently good to drive the development of automated assessments. There are even more opportunities on the horizon driven by advances in computer vision, and there are use cases for such tools, especially in cases of early pre-screening for general population and quantifiable metrics that can kind of empower clinicians to make optimal use of their resources by tracking all of these movement features in videos that are easy to obtain for parents. So that is all from my side. Happy to take questions.
Thank you so much for that fantastic presentation. As people are typing their questions in, we have one from an attendee from Ghana who asked if we could elaborate on the percentages of GMFCS expected to be reached at each level, especially at level 5.
Yeah, sure, we can do that. I'm going to ask Melanie to go back to the gross motor trajectory figure. We this is a scale. The gross motor function measure on the y-axis was developed specifically for children with cerebral palsy. So it is not norm reference, it's a criterion reference scale. But we do know that on this scale, children who are 5 years of age are expected to score a 100. So if we can sort of look at the point where a 5-year-old would be 100, sort of drawing up that vertical dashed line all the way to 100, we could see that a child at that same age, 5 years of age, on average is performing about a score of about 20. This is a Rasch analyzed weighted scale, so it does reflect about 20% of the gross motor ability of a typically developing 5-year-old at that age. And so we would see over time, if we look at the more plateaued areas of the curve from about 6-7 years through 15, we would see that children at level 1 in general, these are average curves, don't forget, so individual curves would be, above and below the average here. But children functioning at level 1 are on average reaching about 85% of the gross motor skills of their typically developing peers. Children at levels 2 and 3, children at level 2 closer to 60 or 70%. At level 3, it's about half. They are unable to walk independently for most of their ambulation. They need an assistive device. And then children at levels 4 and 5 are achieving less than half of the gross motor function of their peers.
That's great. Thank you.
Sure.
As we're waiting for more questions to come in, just a question for me around how do you see this being used clinically, if at all? Can you talk about a little bit about the clinical implications potentially of this process?
Sure. Yeah, we're hoping that the data, the approach that Melanie presented, can be useful as really a global screening tool. And so this could be very short videos recorded of an infant by an app, and the software could return a risk level. So we see this having potential to be integrated into many settings where infants, even well baby, sort of general health checkups of infants. So pediatrician well visits, community health worker check-ins with families after a newborn has arrived. So a very quick global screening. And then we also hope, what we didn't present today in detail, is we have some more comprehensive tools to measure infant movement as well that require in-person testing. And so we would hope that those, in combination with the existing clinical tools, could be used for definitive diagnostic information or stratifying participants to particular therapy or intervention programs from which they are most likely to benefit. So the work that we presented today as a global screening tool, and it's quick and easy and accurate enough to serve that purpose, but more comprehensive in-person testing we think will be needed, although we think we can automate and still improve existing tools for definitive diagnosis, classification, and treatment stratification.
That's fantastic. Good luck with that because
you.
much needed. And I think will make the process a lot simpler and easier, especially diagnostic wise. We have another question from Shiv Hayamat. So a question for Melanie. Melanie, you mentioned that you need a lot of data for the algorithms. Do you think we are heading towards a lot of researchers sharing their data? And for developing new algorithms, such as the ones you mentioned, or will it be difficult, primarily due to HIPAA or patient privacy concerns?
Yeah, so that is actually one of the biggest advances that has happened in the past few years in terms of algorithmic development is the ability to pre-train models on data that is not specific to any one research center. So the algorithm that I'm using at the moment for the infant pose modeling was actually pre-trained on readily available adult human movement data, and then applied to the infants because they have a similar enough human skeleton that the algorithm can actually learn most of the information that it needs from adult human data and then just be applied to the infants. So the benefit of this is that we have dramatically reduced the amount of data that's actually needed from any one clinical population by pre-training on data that is not subject to something like HIPAA requirements. We can then extract the 2D pose data, which is fully de-identified, and share that between clinical sites. So the path forward that I really see for this is doing this pose estimation using pre-trained models, and then sharing what is fully de-identified data and training algorithms specifically on that de-identified data. So we can kind of get around some of the restrictions that were previously, or not get around the restrictions, but get around some of the limitations that were previously imposed by the need to share videos by moving towards a paradigm where we can share pose estimates.
That's great. That's fantastic. I think we can take one more question. I know everyone's on time crunch, but we have an excellent presentation here, and there's several of those. Does this research consider different potentially ethnic or racial groups?
Sure, I can answer that. So the data that we have from our clinical neonatal follow-up population is quite representative of Philadelphia and the surrounding region. It also approximates the population of children in the United States that have developmental disabilities. So in general, and the way that we record ethnic and racial data in the United States is with the guidance from our funders through the National Institutes of Health. So for ethnicity, it is Hispanic Latino or non-Hispanic Latino. That's about 10% of our population. And for racial distribution, it is about 30 or 35% Black African American, about 50% white or European descent, and just under 10% Asian, and the rest is either unknown or multiracial, mixed race. I think our mixed race is about 15%, if I have those numbers correct. So it's representative again of Philadelphia and the surrounding region. It approximates the representation of children with developmental disabilities in the United States. We would not assume that it represents other cultural groups, of course.
Right. But there is a potential that as this grows and as your database grows, that representation would be wider, potentially global as well.
Yes,
So,
yes, that is our hope. Yeah.
That's fantastic. All right. So I'm going to end here. I know we're right at a little after 12 o'clock. Thank you, everybody. Thank you to our fantastic presenters today for this amazing talk. A lot to think about and a lot to look forward to from this group. And hopefully we'll have you back at some point talking about the advances and where we've reached or the kind of data you've been able to collect. Just a reminder to our attendees, we will have an August GPMR webinar, and we'll send that information out to everybody who was on this call as well as who's been on the call before. So thank you so much for being here.